Hey everybody, this is Dr. Medicine Alex, and in today's video we'll be discussing about Puva therapy. So Puva therapy is a type of photochemotherapy that is done with Sorolens, and it combines the use of oral or topical Sorolens and UVA ultraviolet A radiation. Hence it is termed as Puva. So the Sorolens used, the conventionally used Sorolen for Puva therapy was methoxyline or 8-methoxysorolin. Others include trioxolin or 4,5'8 trimethylsorolin, bergaptan or 5-methoxysorolin. 8-MOP is naturally occurring and it is more phototoxic after oral administration, whereas trioxolin is synthetic and it is more phototoxic when used topically and less phototoxic orally. So coming to mechanism of action, so there is going to be inhibition of DNA, RNA and protein synthesis by this Puva therapy. So it forms bifunctional adducts with cellular DNA, thereby inhibiting the DNA synthesis. And it also generates oxygen reactive species which bind to the RNA and cellular proteins. And it also has an immunosuppressive effect where it depletes the Langerhans cells and also induces apoptosis of CD4 lymphocytes. It also acts by stimulation of melanogenesis, where Sorolens stimulate mitosis and proliferation of melanocytes on photoconjugation. They also increase the melanization of the melanosomes. They also increase the transfer of melanosomes to keratinocytes, and they also cause increased synthesis and activation of tyrosine. Coming to indications, the US FDA approved indications are for psoriasis, mycosis fungoides or Sézary syndrome, and also vitiligo. However, certain other disorders such as the papilloscomus disorders, atopic dermatitis, seborrheic dermatitis, chronic hand dermatitis, palmoplantar pustulosis, lichen planus, parapsoriasis, pityriasis lichenoides, and lymphomatoid papulosis also use Puva therapy in certain cases. They can also be used in photosensitivity dermatosis, where they act by causing an hardening effect, such as in polymorphous light eruption, erythropoietic protoporphyria, solar urticaria, chronic acne dermatosis. In certain neoplastic disorders such as Langerhans cell histiocytosis, in pruritic dermatosis such as dermographism, aquagenic urticaria, chronic urticaria, polycythemia vera, idiopathic pruritus, urticaria pigmentosa, prurigo nodularis, and certain other immunological dermatosis such as alopecia areata, GVHD, morphea, and systemic sclerosis. Coming to treatment procedure, so first there is going to be methoxysalin administration. It can be topical or oral. Topically, we ask them to apply 8-MOP, which is available in the form of creams, ointments, or lotions, and this is followed by UVA irradiation. And it is used for limited plaque psoriasis and palmoplantar disease. So for limited lesions, we go for topical administration of 8-MOP. Then there's something called as bath photochemotherapy, where the whole body is immersed in solutions of 8-MOP or TMP, which is added to 100 liters of water in bathtub for about 15 to 20 minutes. And this is followed by immediate irradiation. And TMP is more phototoxic after topical application, so it is preferred and it is used at lower concentrations than 8-MOP. Coming to oral administration, so for this we can use 8-methoxysorolin at a dosage of 0.4 to 0.6 mg per kg, or trioxolin at a dosage of 0.6 mg per kg, or 5-MOP at a dosage of 1.2 to 1.8 mg per kg. However, 5-MOP is not used in India. So the patients, they take 8-MOP orally as capsules in a dose of 0.4 to 0.6 mg per kg body weight, and the medication should be taken 30 minutes after a light meal because it will reduce the nausea that is associated with 8-MOP, and this is followed by UVA exposure after about 1 to 3 hours. And UVA administration, so the action spectrum is reported to be between 320 and 400 nanometers, and the sources that are used for this UV administration are fluorescent lamps which have an emission peak at 325 nanometers, or high pressure metal halide lamps. The initial UVA dose is determined by either the patient's skin type or by MPD testing. So the MPD is defined as the minimal dose of UVA that produces a barely perceptible but well-defined erythema when template areas of the skin are exposed to increasing doses of UVA. So the frequency of treatment, it is going to be 2 to 3 times per week with dose increments of 0.5 joules per centimeter square. And other forms of UVA administration can be bathing suit Puva, turban Puva, soak Puva, turbo Puva. Coming to adverse effects, So short-term adverse effects of Puva therapy include phototoxic reactions, symptomatic erythema, pruritus, subacute phototoxicity, photoneurolysis, Koebner's phenomenon, friction blisters on hands and feet, and even ankle edema. And attributed to methoxyline alone, there can be GI disturbance, central nervous system disturbance, bronchoconstriction, hepatic toxicity, and drug fever exanthems. And certain other adverse effects include cardiovascular stress, herpes simplex reactivation or recurrences, and photosensitive eruptions. Now, coming to the long-term adverse effects of Puva therapy, is going to be photoaging, non-melanoma skin cancer, cataract, even melanoma and internal malignancies. Coming to contraindications, the absolute contraindication is patients with pemphigus and pemphigoid or lupus erythematosus with photosensitivity, xeroderma pigmentosum, pregnancy, lactation, and history of idiosyncratic reaction to the psoralen compound. And certain relative contraindications include photosensitivity or patients on photosensitizing medications, or prior exposure to ionizing radiation or arsenic, history or family history of melanoma, history of skin cancer or chronic photo damage, severe cardiac, liver, or renal disease, and a very young age. Coming to pregnancy. So in pregnancy, it is a category C drug. So it can be used, usually NB-UVB is used. And combination therapies, it can be used in combination with other topical and systemic agents such as topical adjuvant therapies with glucocorticoids, anthralin and tar preparations, calcipotriol, and even tazarotene. Systemic drugs, methotrexate, it is used only during the clearing phase, and long-term treatment with of a Puva and methotrexate can cause development of skin cancers. So one should be cautious when the patient is on methotrexate before starting Puva therapy, especially in cases of psoriasis. And cyclosporin, there is going to be increased risk of cutaneous squamous cell carcinoma. So usually Puva therapy and cyclosporin are not put together. And retinoids are actually pretty effective when they are given with Puva therapy, and this is something called as a Re-Puva, and it is highly effective, and usually it is done in various cases of psoriasis. Thank you. Subscribe for more.